All right, we're going to try to go ahead and barrel through depression, bipolar, and suicide without a whole lot of interruptions. If there is an interruption or technical difficulty, I'm just going to keep going, especially if it's later on in the slides, as this is about the fourth time that I'm trying to record this video, as is probably seen by what is popping up on my screen. As you guys will remember, depression belongs to a class of internalizing disorders. It's a Freudian term. It means that people turn their distress inside. A subclass of internalizing is anxious misery, and MDD belongs to that bucket of anxious misery. The other disorder belongs to the anxious misery bucket is generalized anxiety disorder, and unsurprisingly, that is the most comorbid disorder there is with major depressive disorder. It shows genetic overlap, it shows mechanistic overlap, they have similar trajectories, so it is the closest relative included, and that's unsurprising because they also have actual direct symptom overlap. That's not to say that MDD is not comorbid with other disorders. It is. It's comorbid with fear-based disorders, OCD-type disorders. It's going to be comorbid with externalizing psychopathology, including drugs and alcohol abuse, and then it's going to be comorbid with psychotic disorders. But the closest relative is generalized anxiety disorder in terms of comorbidity. So briefly, diagnostic criteria. You need one of two gateway symptoms at least. Gateway symptoms, either depressed mood, most of a day, nearly every day for 2 weeks straight or more, or anhedonia or lack of interest or pleasure in things you would usually enjoy, things you would usually find rewarding, most of a day, nearly every day for 2 weeks straight or more. Then you also need 4 of the following symptoms in addition to that one gateway symptom. So you need disturbances in sleep, disturbances in activity level, disturbances in food intake and appetite, disturbances in, again, energy levels, loss of energy, feelings of worthlessness or excessive guilt, cognitive disturbances, and thoughts of death and suicide. Let's go ahead and take a look at this video. I'm going to share a different screen now. And it's a bit of a lengthy video, but what you're going to see is that the patient will display most of the symptoms and some of the ones I didn't discuss when you see her. And that is going to be here.
Hello, Alison Wells. Do you want to come and have a seat? Hi, I'm Dr. Taylor, one of the GPs at this surgery. What would you like me to call you?
Alison will be fine.
Okay, okay. So what has brought you here today, Alison?
My sister's medicine. I'm just a bit fed up, really.
Right, okay.
My sister said I should come.
Right, okay. Has this been going on for some time?
Yeah, a few months.
Okay. Do you want to tell me a bit more about what's been going on?
I just things seem to be piling up.
Right.
I just don't seem to be coping with things.
Right. Okay.
With kids and things.
Right, okay. Would it be okay, Alison, for me to ask you a few more detailed questions about how you've been feeling? Okay. Well, if we start with asking you a bit about your mood, how have you been feeling in yourself?
I say a bit fed up. Wake up in the morning, everything just seems very black.
Right.
It's just like swimming in treacle, really.
Right.
I just don't. I think by tea time the kids get home. So I've been having a fairly decent conversation with them.
Right. And can I just check, Alison, when you say things feel very black, do you mean you feel very miserable?
Fed up, miserable.
Right. Okay. And what about sort of feeling tearful? Has that been happening?
I dropped some sugar the other day. I had asbestos.
Right. Okay. So is it the slightest thing that would make you feel tearful? Things that perhaps wouldn't ordinarily bother you?
Yeah.
Right.
My sister's noticed as well.
Right. Okay. So you've been feeling very low, and there's episodes of tearfulness.
Yeah.
What about other things? What about your energy levels? Are you managing to keep up with things?
I used to do a lot with the kids. We used to go swimming, playing, but now I just spend the day on the sofa, really, unless I have to go to work.
Right. And just remind me, what is it you do for your job?
I work in the supermarket.
Right. So how have you been managing at work?
I'm not been going in as much because I just feel so exhausted. But I mean, we're just not. The supermarket's been taken over and they've cut the wages.
Right.
And I'm having problems with the bills.
Right.
And it's like catalogues, it's writing me letters.
Mm-hmm.
You know, the kids, they want all these new games and stuff.
Sure.
It's just, you know.
I think things are really difficult all round. With all this going on, how are you sleeping, Alison?
It takes me ages to go to sleep.
Mm-hmm.
I used to read a book.
Right.
And just drop off.
Right.
But now I just spend my time looking at the clock.
Right.
So it goes round.
So from actually getting off to bed and getting off to sleep, how long is that taking?
A couple of hours, probably.
Right. Okay. Once you're actually asleep, are you waking up much during the night?
Well, I wake up about, last night I think it was about 4 o'clock.
Right.
I wake up.
And can you get back to sleep from that time?
No.
And then when you're actually getting out of bed in the morning, are you still feeling tired at that point?
Just exhausted. I feel like my brain's not been switched off.
Right.
And I'm just exhausted the next day.
Okay. What about eating? What's your appetite been like while you've been feeling like this?
I used to have quite a weight problem, but the last couple of months, I mean, it's just a bit looser.
Right.
I just...
Do you know how much you've lost?
No. The kids come in from school and they make their own stuff and I just don't bother really.
Okay, so your appetite's gone down as well. What about things like concentrating in your memory, both when you, I don't know, watching TV at home or out when you're out doing your job? How have those things been?
Well, they're pretty useless with the kids. I've got the swimming money last week and
Right.
PE kit and parents even.
Right, okay.
Well, I just start one job and I'd like, I'm not explaining myself very well. It's like the television. I used to like watching the soaps.
Sorry about that.
EastEnders or something, and now 10 minutes later, I just, I'm thinking of something else.
Okay. And what about things, Alison, that you used to enjoy? Are there things in life that you still enjoy at the moment?
Nothing really. As I say, a bit useless with the kids. I used to enjoy going out.
Right.
I used to go out with my friends, the pictures and things.
Right.
But of course, now I just can't be bothered.
Is it you can't, whether you don't feel like it as well?
What's the point, really?
Okay.
You know?
And I was going to ask, how old are your children now?
I had them a bit later in life. It took a long time for me to have them.
Right.
I've got a girl and a boy. One's 11, one's 9.
And looking after children takes a lot of time and energy. How are you managing to keep up with that, feeling as low as you do?
Well, a bit self-sufficient, really, the kids do. They come in from school, get their own tea.
Right.
I should be doing more for them, really, but I'm just being useless at that moment.
And what about looking after yourself?
Well, you can see I'm just a mess. Dave used to say, that's my boyfriend.
Right.
I used to, not have much money, but I just take a bit of pride in what I was doing, you know.
Right. Okay.
And my hair and stuff, but I can't be bothered with that now. There's no point, really.
Okay. And you mentioned Dave, that's your current partner. How long have you and Dave been together?
About a year I met him.
Right. And how are things, because often when people feel really down, it has a real impact on everything, including their relationships. How are things between you and Dave at the moment?
But he's not ringing as much.
Right.
He used to text. But he's going, you know, he's getting fed up with me not wanting to go out.
Right. Okay.
And things.
It's a slightly embarrassing thing to ask about, but I guess it's important. Often when people are really feeling very low, it affects everything in their relationship, including things like the sex life. Have you noticed any changes there for you?
He's always trying to pressure me a little bit and stuff, but I'm really not into that at the moment.
Okay, just don't feel like that at the moment. Okay. So can I just recap, Alison, and check I've got this right? For the last few months you've been feeling really down, no energy, problems with your sleeping and eating, problems with concentrating, not really enjoying things, and actually struggling a bit with the kids, and perhaps some difficulties in your relationship with Dave. Have I got that right? Okay. Can I ask, Alison, in the past, have there ever been episodes in that you felt like this?
When my husband left, I was always crying then for no particular reason.
Right.
I haven't told anybody this before, but I took some tablets.
Right. So how long ago are we talking about? Is this a few years ago?
About 4 years.
About 4 years ago. Okay, so you took some tablets.
Yeah.
Can you is it all right? Tell me a little bit more about that.
Well, it's like kids are in bed. You're on your own and I had a few glasses of wine.
Right.
And I just took these tablets.
Right. Okay. Can you remember what you actually took at the time? What sort of tablets were they?
No, just in the bathroom cabinet. A bit of paracetamol.
Right. Okay. So you took some paracetamol. Can you remember sort of roughly how many you took?
It was 2 strips, about 12.
Right. Okay. And you'd had a couple of glasses of wine. Did you take anything else? Any other tablets with it?
No.
Okay. And was this something, Alison, that you'd thought about for a while? Or was it something that was quite a sort of spur of the moment decision that evening?
I mean, crying a lot, but I think it's wine.
Right. Okay.
But, you know, it's a bit of a burden to everybody, really.
Right. And was there any other things that you did around the time? Sometimes when people take tablets, they leave a note or do other kind of final acts, get their affairs in order. Did you do any of those things?
No, just sort of, you know, take the tablets and go to sleep.
Right, okay. So did you have any thoughts about what taking the tablets would do? Did you?
But I just thought I'd go to sleep and not wake up, but I woke up a couple of hours later and I was sick everywhere. God, I was sick.
Okay. So you actually went to check and get this right, because at some point you actually thought they would kill you at the time?
I just didn't want to wake up. I just was saying I'm so useless. I'm just a useless mum now, and I was then.
Right, okay. So you took the tablets, you were very sick in the night. Did you seek any medical help at the time?
No.
Okay. And then, you were okay the following day?
Well, yeah, I just felt a bit of a twit, really.
Right. Did you feel pleased that you were still alive?
Yeah, I think, you know, I realised it was just being silly.
Right, okay. So that was a few years ago. So if we just come back to how you're feeling at the moment, you've talked about feeling very low. Have there been times currently when you thought about either taking an overdose or doing something else to harm yourself in any way?
You know, at night when you're watching the clock and, you know, you're on your own, the kids are in bed. Everything's so hard. And yeah, I suppose, you know, it just feels easy, you know.
Right. And has that just been something you've thought about? Or have you actually made any plans, got any tablets in, or done anything else?
No,
okay.
No. Nothing like that.
Okay. And I guess it's a difficult question to ask, but one we would ask everybody in your situation. Have things ever been so bad, you felt so low, that you've not only thought about harming yourself or perhaps killing yourself, you've also wondered whether the best thing might be to take the children with you.
No, I've never had my kids. I love my kids.
Okay.
No, I wouldn't hurt them.
Okay.
No.
And what about sort of the other side of that? Things, positive things, sort of things to live for? Things that you feel good about?
Not much at the moment, I suppose. Kids sometimes, you know, they do things that make you think, you know, I think what's good about life and things, but...
And are there other things that help at the moment? I'm thinking about people who can be supportive.
My sister, as I say, she said to get down here, and she's always there. She comes down and rings. Got a couple of friends that they're quite good.
Right.
Well, and Dave, when he's in the mood, of course. Sure. But I don't think he's going to be around for much longer.
Right. And do you feel able to keep yourself safe at the moment from hurting yourself?
I think so, yeah. And I know I can come here now. You've been very good today.
Okay. Do you think if that was to change, so that you didn't feel you were able to keep yourself safe, you'd be able to let anybody know?
Well, I know what happened last time. That was nothing, and I know I was silly then. So I know to come here.
Right. Okay. Okay, Alison, well, thanks for going through all that. I can appreciate it must be very painful. It does sound to me like you are suffering from symptoms that strongly suggest that you're actually depressed at the moment. Now, I'm not sure how much you know about depression.
Not much really, not much, but I just don't feel right at the moment.
Well, I guess just briefly, depression can cause a number of problems for people, and traditionally we think about people feeling very low and very miserable and often, you know, thinking about hurting themselves, but it can also affect all other areas of life in terms of problems with eating and sleeping and the other problems you've noticed, things like concentration, perhaps not really managing as well as normal. I guess the positive side is that you've done something about it and you've come to talk to me about it today. And I think there are almost certainly a range of things we can put in place to help you and treatments that are available. So I guess what I'm thinking is it might be worth us just spending a few minutes just thinking about some of those options for you so that we can start to improve things for you. Would that be all right with you?
I need to do this, yes. And I think sensible, yeah.
Okay.
Okay, good. Right. We are back to the lecture. Guys, keep in mind everything that she said. The interviewer, the therapist, whatever she is, did actually a very nice job of underlining which symptoms, which depressive symptoms Alison actually has. So I'm not going to rehash that here. What I am going to point out to you to watch out for is the interpersonal problems that she is having with her boyfriend, the lack of social support, and not a whole lot of friends that she has. The other thing I want guys to pay attention to once we get to talking about suicide is she has many of the risk factors for actually hurting herself. So the therapist is very right to be concerned. During the last suicide attempt, there was alcohol involved, hopelessness, impulsivity, also the actual ability to take the pills. So, and finally, she also feels like a burden to herself and others. That's going to be a problem and it's a major factor in risk assessment. But we'll talk about that a little bit later. Moving on. So, epistats. Lifetime prevalence in the U.S. population is about 17%. In any given year, about 7% of people meet criteria for major depressive disorder. MDD is episodic, so once you have it, it has a tendency to recur, and the average number of lifetime episodes is about 4. Think of this, as you will see, as sort of a weakening of a system. Is once you have it, it's a lot easier to get it again. And a lot of the time, people don't get out of depression completely. they'll have a reduction of the number of symptoms, maybe down to 1 or 2, but they may not come out of depression completely. And if the more symptoms you have that are residual, the more likely you are to have a recurrence of MDD. Gender ratio. The gender ratio in depression is one of the most notable things that we know about. And there's a lot of really interesting theories, which I'll touch on in the future, that try to explain the gender ratio. Here's what's interesting. Up to puberty, up to about age 12, 13, there really isn't much of a gender difference, the same prevalence among boys and girls. But once you start hitting puberty, the rates start diverging quite dramatically up until they hit a 2-to-1 female to male ratio. So girls have twice as much rate or risk for depression as boys after adolescence and throughout adulthood. And Susan Ellen Hoxema thinks that she has an idea about why that is. But we'll get there once we get to cognitive theories. Age of onset. Adolescence, late to early adulthood, like many psychiatric disorders, is between the ages about 16, 17 to 24 is when it's going to be the greatest risk of onset. There's a little bit of a second window of onset, but a second window of opportunity, I have a tendency to call them, and that's after 60 years of age. That one is a little bit more tricky because after age 60, there's a lot of other cognitive and physical problems that may masquerade as depression, will give some of the same symptoms of depression, certainly the fatigue and difficulty concentrating. So it can be a little challenging to make a differential diagnosis and say with any certainty that this person is suffering from depression after age 60 rather than whatever comorbid dementia, comorbid health illnesses. Comorbidity, as I've mentioned before, generalized anxiety disorder is a sister, close twin, close cousin, I guess, to major depressive disorder, but it's also comorbid with alcohol and illicit drug use disorders. It's comorbid with eating disorders. It's comorbid with personality disorders. It's comorbid with antisocial personality disorder. And that's why I frequently call it the common cold of psychiatry. All right. This is also another slide that we've talked about in class. So 3 points. Very high rates in Native Americans, surprisingly low rates in African Americans. In fact, several of my friends who study health disparities actually have remarked that African American folks are remarkably resilient to depression. This is especially notable because unipolar depression is inversely related, negatively related to socioeconomic status. And that's a very reliable finding, I believe, across 6 countries. Again, another chart that we discussed in class. And what you're seeing here is risk of depression by cohort. And the blue line is closer to your grandparents' generation. The red lines, your mom and dad, same thing with the yellow, and the greens are most likely going to be you guys. And with each subsequent cohort, the risk of depression is increasing, and it seems to be having an onset earlier. And we've made some in-class guesses to why that is, but of course people can read all about on Google Scholar for various theories about this. Let's switch over to etiological models. Once again, some of this is going to be a repeat, but a lot of it is going to be new. So, are family factors involved in depression? Specifically, are genes? Yes, starting with family studies. You guys should remember what a family study is. That is when you take folks with depression, we call them probams, and then folks without depression, and we look at the prevalence of depression within their family. So usually moms, dads, siblings, aunts, and uncles, if you want to really collect a lot of data. And what we find in family studies is that depression is 2 to 3 more times more common in families of depressed probams compared to non-depressed probams. But you will also remember that you can't tell much in a family study because any given family study provides both genes and environment. So it's really hard to tell what the actual influences are, or for that matter, how they interplay. So we move on to adoption studies to try to get a cleaner understanding of how much genetics and shared environment actually contribute to depression. And so we do find some very strong evidence for genes. There's more depression in biological relatives of depressed adoptees, and vice versa. And when you move to the classical twin design, you have you can estimate heritability estimates, and you get something like about 30%, 37% is accounted for by genetic factors in major depressive disorder. That's not terribly high. The rest is accounted for by non-shared environment, things that are unique to a sibling or a twin. Guys, remember, this does not mean that you personally have a 37% chance of developing MDD. Heritability estimates, twin models, those are population-based estimates, so just be careful with that. For about a decade or more, we were playing around with candidate gene studies in depression and all other phenotypes. There have been several identified: the DRD4 that has to do with dopamine, the 5-HTT which has to do with serotonin. But with any candidate gene studies, guys, remember this, tattooed in your forehead, they don't replicate. And most of the studies were originally done with very, very small samples. Right now, we understand that you need upwards of hundreds of thousands, if not a million people to really understand the genetic contribution of any one given gene, because virtually all complex phenotypes are polygenic. So while there's still some studies floating around saying, oh, I found this gene for depression or this gene, don't believe it. Depression is one of the most complex polygenic phenotypes that we have that constantly interacts with the environment, that allows genes to switch off and on, and you're going to see how that works actually in a few minutes. So any one gene is going to be less than helpful in trying to explain MDD. All right, just a very brief summary of the neurobiological factors in major depression. This is across a variety of structural and functional fMRI and also various theories. So yeah, there does seem to be a genetic component to depression, not terribly high, but also not trivial. There does seem to, the serotonin and dopamine systems seem to be involved in depression, but it's really not clear in what direction or how they're actually involved. Serotonin and dopamine are involved in most mechanisms and most disorders, and they have they're expressed all over the brain and body. So where our science with these neurotransmitters, which are the messenger neurotransmitters, is still in its infancy. Cortisol dysregulation, definitely present in the HPA axis, that is disrupted. And that we actually have a fairly good understanding of how that works, and I'll get there in a few minutes. There are definitely changes in the limbic system, which is responsible for processing emotion in the brain and talking to the frontal cortex. And then low activation striatum in response to reward, which is consistent with the idea of anhedonia. So far, so good, I'm hoping. All right, let's get this thing out of the way. Once again, neurotransmitters. This is probably one of the most popularized hypotheses out there, is the neurotransmitter deficiency hypothesis in major depressive disorder. Originally, the models focused on absolute levels of norepinephrine and serotonin. And at this point, you probably have heard of the serotonin deficiency hypothesis. This is very tied to the idea of SSRIs. The old idea of serotonin deficiency is that you don't have enough serotonin basically floating around your cerebrospinal fluid. that the cells that release it to talk to the next cell over suck it up too quickly back inside to recycle it, and there's just not enough floating around. So what SSRIs do is they keep the serotonin in the presynaptic terminal, and they keep it from getting sucked back up into the cell for recycling. There's a lot of problems with this hypothesis. It's been highly popularized, but it's getting weaker year by year and by year. Medications like SRIs affect the levels of serotonin immediately, but the relief takes 2 or 3 weeks to work. So it doesn't seem to be straightforward. And also, for some patients, there's a spike in the monoamines, and many patients actually with depression appear to have too much serotonin. So with that all said, indiscriminately trying to hand serotonin reuptake inhibitors to all and sundry may be not just ill-advised, but actively dangerous, because we don't have a good understanding of serotonin, of how serotonin works in depression, or for that matter, norepinephrine and dopamine. More studies are now coming out with different models of of how serotonin is involved in depression. So some new models talk about the sensitivity of the postsynaptic receptors, the receiving ends in the chemical messaging process. So one idea is that dopamine receptors might lack sensitivity in MDD. And when it comes to serotonin, the idea is individuals who are vulnerable to depression might have less sensitive serotonin receptors. And as one example of this logic, if you deplete tryptophan, there's a certain drink you can give people and depletes their tryptophan, the serotonin precursor. It causes a spike in depressive symptoms among individuals with personal or family history of MDD. That's one model of serotonin and dopamine dysfunction. Paul Andrews thinks, Paul Andrews, who's not on the slide, but he has a slightly different model. He says that serotonin is actually positively related to depression, more serotonin and more depression, and that when we give people SSRIs, it drives the levels of serotonin even higher, forcing the receptors to downregulate so that they're less sensitive to serotonin. And that's his account of how it works. But right now, the jury is out as to the exact mechanism. So be very, very careful, both on the test and in real life. This is just a nice picture of how all of this is expressed in the brain. Anything purple is the dopamine, gets made in the substantia nigra, shoots over to the nucleus accumbens and gives a dopamine squirt. Now, most people think that's pleasure. No, it's actually much more tied to motivation, not pleasure itself. Pleasure comes later with a byproduct of dopamine. So then it goes up through ventral tegmental area, gets expressed in the hippocampus. There's plenty of dopamine receptors in the hippocampus. And also in the frontal cortex and in the striatum. So reward, motivation, self-control. Dopamine is involved in talking to a lot of different areas in regulating these kind of behaviors. Serotonin, it's a very old molecule, goes from brainstem, gets expressed in I think hippocampus once again, and frontal cortex. So nobody doubts that these are important chemicals. It's just we don't have a good understanding of how and what they do in depression. And it is undoubtedly not the absolute levels of dopamine or serotonin that are actually regulating depression. All right, brief summary of what's activated and what's not activated. This is all results from fMRI studies. Now, before I go further, I need to make a distinction. There's two types of brain studies. One is just structural studies. It's when you're looking at volume within a given region. You're not actually seeing how stuff moves around, but you're looking at absolute volume. The next is functional MRI, and that's when you can actually look at how things function in space, how things move around, and most importantly, this is what you're looking at in fMRI, how much certain brain areas are consuming oxygen. So let's look at what's activated and what's not activated in depression. So the amygdala, this is one of your oldest brain structures, fight or flight, if anybody remembers, is hyperactivated in depression. Anterior cingulate is elevated. That's part of the limbic system. Prefrontal cortex. Sorry about that. As I said, I'm not going to remake this, the presentation from scratch. Just, I think we stopped over at the anterior cingulate. That's your part of the limbic system. Again, anything to do with the older structures of the limbic system seems to be overactivated, but prefrontal cortex, the seat of executive functioning, if you like, activity is diminished. Hippocampus, activity is diminished. So is actual brain volume. And you'll see why in just a second. Striatum, which deals with the reward to some degree, activity is diminished. All very consistent with a clinical account of depression. All right, let's talk about neuroendocrine hypothesis, or how specifically how the HPA, that hypothalamic pituitary adrenal system, plays a role in depression. The other name for this is hypercortisolism. You remember that cortisol is essentially the hormone, the stress hormone is what people sometimes call it. Not quite correct. It's in that ballpark, and but it floats around a lot in your bloodstream when you are depressed. And why is that? Well, let's first talk about depression and cortisol in general. So plasma or blood cortisol level is elevated in about 20 to 40% of outpatients and up to 80% of inpatients. So it seems to be a very marked, very reliable marker. The other thing you have is decreased hippocampal volume in depression. I believe that's actually found in both people who have active depression and those that are at risk for depression. And here's an illustration of HPA and depression tie. Consider a non-psychiatric syndrome, something called Cushing syndrome. This is a type of tumor that causes oversecretion of cortisol, and it will produce symptoms of those with depression. Same thing with studies with experimental organisms. If you take a rat and you pump it up full of cortisol, it's going to produce depressive symptoms like learned helplessness. Now, moving on to humans. One second. Experimental organisms and dexamethasone suppression test. How does dexamethasone suppression test work? Because that's actually in humans. That's human experimental evidence. So dexamethasone is basically synthetic cortisol. If you are a non-depressed person and I administer dexamethasone to you overnight, in the morning your cortisol level should be suppressed because we have a feedback loop in our body. When you have too much cortisol floating around, eventually the hippocampus is supposed to step in and turn off that system. That's not what happens in depression. The feedback loop never actually gets activated, never gets shut down, so you just produce more and more and more cortisol. Now, why is the hippocampus so crucial? It's for a variety of reasons. One is, once again, it is what turns that system off. If the if the hippocampus is somehow impaired, you're going to have a hard time turning off that loop. And what did I say about depression? Is hippocampus is underactive or impaired in depression. And you have, of course, the memory impairments and deficits in abstract reasoning and complex problem solving. And none of that is surprising when you consider the hippocampal system. So that's a pretty good theory of how HPA is involved in depression. Oh, one more thing I want to go ahead and say is that the overactivation, the turning on the HPA axis over and over and over again and not being able to shut it down has not just mental consequences, but physical ones. It contributes to inflammation and cardiac disease as well. So you'll see actually fairly high comorbidity rates between depression and cardiac disease. And this is one contributing theory to that. So those were all the biological factors, but I don't mean to make it seem like depression is all biology and all pharmacology. As I've said over and over again, depression is complex. The systems do not work in isolation. They work in concert with each other. They're like an ecosystem that's embedded within a social ecosystem, a larger social ecosystem. If anybody remembers Bronfenbrenner, and his ecosystem model of development and human behavior. Depression kind of works like that. It's embedded in a larger context. So what larger context, and how do these factors interact with the social context? Let's start with the simplest piece, and that's life events. In a second, you're going to see it's not simple at all. So we always think of life events as being hugely contributing to depression. And this is unsurprising because even in longitudinal studies, up to 67% of folks report a stressful life event in the year prior to the depression onset. And this was done with actual longitudinal studies. And usually those stressful life events are something like a romantic breakup or loss of a job or death of a loved one. So it makes it seem like something really straightforward is something bad happens to you and then you go ahead and get depressed. Two complications. But before we get into those complications, life events can be actually split up into two types. Dependent, ones that you essentially have somehow brought on, chose, or got yourself into. Basically, ones that are tied to you and your personality. And independent. In class, I used the examples of, so independent is not tied to your behavior or personality. So the example I used in class is a dependent stressful life event might be going to jail because you got a DUI. An independent life event might be Hurricane Irma. All right, what do we know about dependent and independent life events in depression? We do know depressed folk generate dependent life events. And the other complication is those at risk for depression are also more sensitive to stressors. That means that if you take a depressed person and a non-depressed person, expose them to the same stressor, depressed folk are going to rate that stressor as much more stressful than non-depressed folk. So we do know that stressful episodic life events play a causal role in about 50% of the cases. And that relationship does seem to be stronger for the first episode, but it's just not that simple because those events are not necessarily independent from a person's personality. Another piece, very important piece to mention is chronic stress. So ongoing for several months, like poverty or loss of a job or unemployment. That sort of stress increases the risk for onset and maintenance and recurrence of MDD. And this has been replicated worldwide across 6 countries. So it looks like there seems, and finally, there seems to be a lack of social support, which also falls under the rubric of chronic stress sometimes, sometimes not. And that might be one reason a stressor might trigger depression is kind of a lack of social support. For some people who have the social support, it might be protective, and those people who don't have that in place, an extra stressor might tip them over the edge. Let's talk a little bit more about social and interpersonal factors in depression, because this is where it gets really, really interesting without involving pharmacology or biology at all. So the next few slides are going to be all about interpersonal difficulties and dependent life events. What does the person with depression do to generate additional stress? What do they do to place themselves at risk for more depression? You're about to find out. Some interpersonal factors that are majorly contributing is one is expressed emotion by family members. Expressed emotion is a kind of a nice term to really refer to criticism, over involvement, a general family feeling of fed upness, and conflict with the patient. And the higher levels of criticism, emotional over-involvement by family members, the more likely the person is to relapse into depression. Marital conflict also predicts depression. So far, all looks like stressful life events coming from the outside and activating depression, but once again, it's not as simple as you think, because the behavior of depressed people actually generates stress. This is all Connie Hammond's work. I have to step back a little bit. Really, this is tied to Coyne's interpersonal model of depression, and Connie Hammond and Tom Joyner's models, which you'll see all grew out of that Coyne interpersonal model of depression. So Connie Hammond, way back in 91, she showed that depressed women experienced more interpersonal stress, to which they actually contributed, even compared to women with bipolar disorder and medical illness. So, if depression is associated with increased dependent life events, what might folk do? Connie Hammond studies women, so that's why this is about women. That's mainly what's in her studies. But what might men and women do to actually generate stress in their lives? And one idea is poor problem-solving skills, which can be expanded upon, actually. But the idea here in the next study is poor problem-solving skills might result in stressful outcomes, and specifically poor interpersonal problem-solving skills like conflict management. Now, they don't just have an idea. They have some data. And let's take a look at that data, those data, actually. All right. So this is a path model. I believe it's a longitudinal study. The numbers are regression weights. They're standardized. That means that you read them from 0 to 1 and 0 to -1. The closer it is to 1 or -1, the stronger it is. A little star next to it indicates statistical significance. This right here is initial depression at time 1. This is problem solving at time 1. This is stress, time 2, and follow-up depression, time 2, I believe. So what we see is obviously initial depression predicts follow-up depression pretty strongly, but also initial depression predicts stress, and low problem solving also predicts higher stress, or higher problem solving predicts lower stress, hence the negative beta weight. And stress predicts follow-up depression, even accounting for initial depression, and all of this is statistically significant. So this is nice, compelling evidence for the interpersonal model, and it's going to start being filled out a little bit more. All right, skipping forward a few years, this is still Connie Hammond's work. This is kind of a fun study. So she takes 812 community women, formerly depressed, currently depressed, and never depressed. So formerly and currently depressed are actually kind of similar, and that's going to be important to see in a second. So formerly and currently depressed compared to never depressed are less likely to be stably married, poor marital satisfaction, problematic relationship with friends, kids, and family. Oh, look, this is starting to look a lot like the video we just saw with the clinical case study. More stress with interpersonal conflict and content. So the stressful situations they're having are interpersonal conflict related. And here's a fun one. This has to do with not quite clear how this works. A lot of people have a few ideas, but the spouses, friends, and boyfriends of depressed women had greater pathology themselves. Interesting. So some empirical data along the same lines, still from Connie's group. Depression stimulated, this is, again, regression weights or correlation ends up being the same. Closer to 1 or closer to -1 is good. All of this is going to be statistically significant. So let's go through it. Depression is correlated with having stressful issues with your best friend, having romantic stress. It's negatively associated with participant report of emotional support and partner's report of emotional support. And here's your psychopathology of friends and partners. Depression in the woman, in the patient, is correlated with what used to be called cluster A, the schizotypal, the paranoid personality in friends, and in all types of personality disorders across all various spectra in romantic partners. So this is across the board from the otter schizophrenia spectrum type disorders to the dramatic disorders to the ones to things like avoidant dependent. So there seems to be some sort of mechanism of either selection or influence by romantic partners that's going on. All right. So all of this was extended by Joiners in a really nice article called Depression's Vicious Tree. For you guys' knowledge, Tom Joiners up the road at FSU. He proposes two rough types of processes that contribute to depression, in terms that are self-propagating and erosive. Self-propagating processes are active behaviors performed by the person to maintain depression, and erosive are more scarring or passive processes. Where depression erodes resources. And both of these things contribute to depression chronicity, having so that longer episode duration, more probability of relapse soon, and recurrence. All right, so it's a fun model. He proposes 4 mechanisms of stress generation that fall under erosive and self-propagating. Let's go through them. So, negative feedback seeking. An example of this. Oh, this was dumb of me. I messed up. I'm a horrible person. I'm so stupid. Okay, why would somebody with depression do this? And it seems that folks with depression, sorry, one second. Let me start over again. All right, let's try this again with the negative feedback seeking. Once again, that's when a person basically asks for the confirmation of how terrible or unintelligent or worthless they are. And it's really, at first blush, it's not really clear why a depressed person would do it. And then you start thinking, it becomes a little bit more clear. And it has to do with being consistent in your own head with who you think that you are, that even if it's bad, if it's consistent with your own schema of who you are, you find it reassuring to hear things that match. Oh yeah, no, I knew I was terrible and this just confirms it. I suddenly feel better. So it has to do with the need for dependability, for predictability, control, familiarity, and some experimental studies from Swan have shown that low self-esteem people are motivated to seek negative feedback. And they'll also preferentially solicit, attend to, and believe self-verifying feedback. All right, let's go on to the next piece. So interpersonal avoidance. It's actually not that difficult to figure out how interpersonal conflict avoidance probably what Connie Hammond was talking about with the poor problem-solving skills or interpersonal problem-solving skills, how it contributes to depression. So you end up, if you end up avoiding conflict, you end up giving things up, either at your job or at your home or within a relationship. You don't exactly feel great about yourself after you just start losing stuff because you're not standing up for yourself. And and then also you're demonstrating a very submissive posture, which may not be something that you're happy with. So all of this would also generate further depression and also loss of resources. I mean, if you're giving things up, physical things or ground in a relationship over and over again, you may never regain it. All right, next one. Excessive reassurance seeking. So this is a tendency to seek assurance from others as to your worth and lovability, even when that assurance has been provided over and over again. So here's what happens is, tell me you love me. Okay, I love you. No, you don't love me. Tell me you love me again. And this goes on and on and on. At some point, the partner or the other person starts snapping. Is, how many times can I tell this to you? And they start losing patience with the depressed person and start pulling back. So it's because it's very unpleasant to attend to and to attend to over and over again. Now, the last point is actually interesting. It's on the part of the folk that surround the depressed person. Basically, the idea is that depression changes the relationship and it changes the partners and the friends' schema of you. And especially when you have engaged in behaviors that are counterproductive or depressogenic, people have a tendency to remember, and they might have changed their cognitive idea, their idea of you, to match depression, to match some unpleasant behaviors you may have engaged in while in an episode, even if you're now recovered. So I guess the idea is you're now recovered, but the person still sees you as this depressive, suffering or whatever person, and it can become a self-fulfilling prophecy as well. All right, let's talk about kind of a mix of things. Some of the things that are on the slide are vulnerability and protective factors or mechanisms, and other things are kind of mechanisms and also kind of paradigms. I'm talking about the cognitive and behavioral theory. So let's just work through it. Social support, existing patterns of social support. Excuse me. We've talked about quite a bit. Neuroticism is an interesting one. You'll see it in a second, and it goes with low positive emotionality. Both of our personality traits and things that are involved in depression and anxiety, in internalizing disorders. And then we'll have a couple of paradigms. Starting with neuroticism. Neuroticism is a tendency to react with higher levels of negative emotionality. It has a tendency to predict the onset of depression. It's actually a very, very robust predictor, both cross-sectionally and longitudinally. And if you think back to the internalizing model that I've showed you, generally people have agreed or think that neuroticism is what holds internalizing disorders together, that this is their shared mechanism, is neuroticism. All of these disorders that are on the internalizing spectrum are high on this dimension. And neuroticism is actually a classic dimension. It comes from Ocean, if you remember the Ocean 5-factor model, but it also shows up in other personality models. Low positive affect is something that people have talked about in the recent years, but are really starting to talk more and more about it as a mechanism in depression. Is low positive affect, less positive response to reward, less well-being. It's tied strongly to that anhedonia dimension, and it is a maintenance factor in depression. These two should not be treated, excuse me, neuroticism and low and positive emotionality should not be treated as kind of the tail ends or the reverse of or same coin of one each other. They're separate dimensions. You can be high neurotic and high positive affect, or you can be low neurotic and low positive affect. You can have any combination. They independently, more or less, contribute to depression, onset, maintenance. All right, getting into cognitive theories, which are unfortunately not my favorite, because all we do these days is cognitive paradigms and treatment. So you guys need to know. The classic cognitive theories were Beck's theory of cognitive vulnerability of depression. It's very brief. Basically, the idea is there's it's the interplay between the negative triad or a negative, so a negative schema, negative triad, and cognitive biases. So all interact to produce depression. So negative schema is the underlying tendency to see the world negatively. That's kind of your mental filter, whether it's rose-colored or I guess black-colored, is everything's going to be all right. No, everything's not going to be all right. Negative triad, you guys remember, it's negative views of yourself, the world, and the future. And together, these factors produce cognitive biases that work backwards to influence negative triad and negative schema, and all of this brings together depression. A little bit of a flimsy model. All right. Next piece, or specifically more cognitive theories. Moving on from Beck is the Anderson and Alloy hopelessness theory. And that actually has a very rich behavioral and cognitive behavioral tradition, which you'll see in just a second. But this is kind of the vocab for the subsequent slides, is hopelessness theory in brief. Focuses on hopelessness, and they Anderson and Alloy think that it's the most important trigger of depression. The idea that nothing good will ever happen, desirable outcomes will never happen, and you have no ability to change the situation, a lack of control. This should start sounding familiar to some of the folk who've taken animal learning conditioning. The other thing to pay attention to within hopelessness theory is the idea of attributional style. I'll show you the questionnaires in a few. Is the factors, the stable and global attributions about yourself and the world can cause hopelessness. So hopelessness theory wasn't always called hopelessness theory. Anybody remember Seligman and the classic dog experiment? I believe it's covered in Psych 100. In 1974, Marty Seligman exposed dogs to inescapable shocks over and over again. Basically, they couldn't get out. And when he exposed the same dogs to escapable shocks, those dogs just basically laid down and refused to move because they didn't believe they could change the situation. They were basically ready to die. They were not very good at escaping once they faced inescapable shocks. So the idea that came out of this very classic study is that the dogs learned the shock was uncontrollable and that they had no way to actually avoid it. This can sound a lot like depression that people experience, is the uncontrollability, unavoidability contributes to depression, and uncontrollability is a pretty reliable factor. But the model had weaknesses, really was developed on dogs, on animal models, and it's hard to model the following with dogs. Take a look. So first of all, some depressives actually hold themselves responsible for things that are happening to them for being depressed, and that's not really consistent with uncontrollability if they're holding themselves responsible. Then some studies that experimentally tried to induce helplessness in humans actually made performance better later on. And then the model accounted for like not moving around, the passivity that you see in depression, but not some of the other symptoms: sadness, guilt, suicidal thoughts. All of these, they don't go, at least the guilt and suicidal thoughts don't necessarily go with passivity or lack of, or the idea that you can't affect anything. These seem to be pretty active ideas or traits. So it's not like the specificity is going to be explaining all and sundry. And then, of course, there's huge individual differences in severity and duration of depression. And if the behavioral model is all that accounts for it, then you really shouldn't see much of a difference outside of what's attributable to the number of learning trials it takes to keep you there with uncontrollable shocks. But anyway, people, especially the folk that worked in the cognitive behavioral paradigm, started revising the model. And what Allo and Anderson did is they added attributions, the person's own explanation, cognitive filter for events in their own behavior. So they're talking about a few attributional dimensions they care about. One is stable or unstable beliefs, global versus specific beliefs, internal versus external attributions. You'll see in just a second examples. So this is the model put all together, the revised, what is now called the hopelessness model. So the idea, negative life events. Person experiences negative life event. They attribute it to stable and global causes. Then the next thing they do is they catastrophize about the consequences of events. That's part of the attributional and the cognitive style. They think that this negative event means they're flawed or worthless, that it means something horrible for the future, that means something stable about themselves. And then it kind of interplays with other cognitive factors like low self-esteem to produce hopelessness. And hopelessness is now is the next step to take you into depression, or specifically the hopeless subtype of depression. So these guys, attributions and other vulnerability factors, which is kind of the garbage category, combine somehow to produce hopelessness or a very specific subtype of depression, which is described on the slide. It's a good theory, I think. It's elegant. I don't think it's going to explain all of depression. I don't think we're going to have one theory that's going to explain all of depression all the time. There's no way. There's just too many ways to get depressed. I want to illustrate what we've been talking about with like cognitive styles and attributional styles. So let's start with cognitive styles. So you've got 12 and 12 positive and negative items, interpersonal items, achievement, and interpersonal things. It's all rated on 7-point type scales, Likert type scales. And it's split up into, probable consequences of each event. So what happens? So how likely is it that you've messed up, or how likely is it that the person, after somebody just broke up with you, that it will mean other horrible things will happen to you? And then the implications of the event for the self. So an example item is going to be along the lines of, to what degree does your receiving a negative evaluation of your job performance mean to you that you're flawed in some way? Okay, so some examples of how we measure this stuff. Attributional styles, same model, just different type of questionnaire. I think this one's a little bit more straightforward. I like the items a little bit more, but that's just a personal preference. So you imagine the situation and then you choose a reason to explain the event if it happened to you. So you get an A. Well, what's your attributional style? Is it internal or external? Are you saying it's because I'm smart, or I'm just happen to be good subject of a test? Or if you play a game and win, Do you acknowledge I played the game well? Or is it no one I know plays the game well? And I just happen to look better than everybody else. We need to go on to the next cognitive theory, which I don't have a ton on in these slides, but you can read about it in both the book and Google Scholar if you like. And the last cognitive theory that really has taken off in the last few years is the rumination or negative repetitive thought theory. This is the idea that people with depression are just more likely to spin their wheels in their head. And the way that they spin their wheels, it's a specific way of thinking, and you're dwelling on stuff, especially dwelling of why did this happen to me? And what does it mean about my life and all these things that it means about me, but mainly, why did it happen to me? It's brooding, spinning your wheels. Susan Nolen-Hoeksema, I believe, she used this model to explain gender differences in depression. Without overburdening you, I'll just say that differences in rumination, the differences between males and females in depression seem to be happening at the same time where the differences in cognitive styles start appearing. So her big thing is this is your key mechanism differentiating between boy and girl mechanisms, levels of depression. All right, switching over to what is a little bit more within my world is the behavioral theory of depression. And it seems to be actually a lot more simple than the other fancy cognitive theories. So here's the behavioral theory, or sometimes known as the behavioral activation theory of depression. So when you're depressed, it results in behaviors that limit positive outcomes. It reduces depression actively and makes you engage in things that reduce pleasure, reduce accompaniment. You stay home more, you engage less, and thereby there's going to be less environmental reinforcers, less things, period, that make you feel good. So it's not just feeling bad or not interested in things that you usually enjoy when you're exposed to them. You're actually exposed to less rewarding activities because you've started isolating, because you have low energy, etc. So in this model, the way that you start trying to fix depression is trying to increase the amount of environmental reinforcers immediately, thinking it's going to change anhedonia, change depression in the long term. All right. Finally, this is probably one of the most well-known studies that we have. For now, it's gotten a ton of publicity, it's gotten a ton of replication efforts, and it still has problems. This is a study by Avshalom Caspi et al., and it was published in Science, the journal, a very prestigious journal, Science, in 2003. This is a diathesis stress model of depression. As a reminder, a diathesis stress is when you take some kind of either biological or genetic or personality predisposition, but it's not really active, okay? So it's not sufficient in its own right. You need to combine it with some kind of a stressor to activate it. And once you have both going on, so about the predisposition, whatever the risk, the liability risk is, and some kind of a stressful life event, that's when you get depression. So Caspi thought the risk was genetic, and it surely is, partially at least. And he focused on a very specific gene, the 5-HT, and he was looking at short versus long alleles of the gene. And what he found is those that were homozygous for the short allele under the condition of a stressful life event, and as stressful life events went up, they were most likely to develop a depression. The heterozygous folk were right in the middle, as you would expect, and the homozygous for the long allele were pretty unresponsive to stress. So the way they sometimes say, this is there's a genetic vulnerability that that makes you differentially responsive to the environment. Now, what do we know about this study? First of all, you guys probably remember what I said about candidate gene studies, and this was definitely a candidate gene. It focused on a very specific gene. Of course, it does not replicate very reliably. People have done a lot of different meta-analysis, and by now, years and years, well, almost 15 years later, people are still arguing about whether it replicates and under what conditions. And this is probably one of the most publicized findings, because genetics just does not work that way in complex psychiatric phenotypes. A single gene isn't likely to do much. So there's a couple of meta-analyses I've seen recently. One says, oh yeah, there's no effect, and the other one says there is an effect. Both of them are in JAMA Psychiatry. So the conversation is ongoing. All right. 1 second, and then we are going to go on to bipolar disorder. All right, let's talk about bipolar disorder. Before we go on, this is Vincent Van Gogh, the owner of, or the location of about half the DSM. This is Virginia Woolf. So Vincent Van Gogh was an artist. You can see some of his work in the MoMA in New York and all over the world. Virginia Woolf is an author, A Room of One's Own, I believe, and a variety of other books, and both of them have committed suicide. Both of them have bipolar disorder, which is why they're on this slide, and ended tragically. All right, first of all, let's talk about bipolar disorder and its location within this internalizing, externalizing psychotic spectrum and its comorbidity. Remember, the whole point of this is to model comorbidity to see, okay, what is the disorders that are most closely related to this disorder? All right. The weird thing is mania, or the mania component of bipolar disorder, ended up with depression on the anxious misery subtype of internalizing dimension. This surprised virtually all of the people who I've talked to. This is why I have a little note down here, is we all thought it should have gone with psychosis. We all have learned that it's on a continuum with psychotic spectrum disorders like schizophrenia. They share mechanisms, they share genes, they share everything, and then this happens. So jury's still out on that. We're still kind of shrugging, going that's not really where it belongs. But at least this is what the empirical data say as of a couple of years ago. So keep tuned, or stay tuned. All right. The diagnostic criteria are actually a little challenging, I know, because I've trained people to administer these diagnostic criteria, and it takes a little bit of training. So you need a time period, and the specific time period is a little tricky, where you have either distinctly elevated mood or distinctly irritable mood for most of a day, nearly every day, and it has to be abnormally. And you also should have abnormally increased activity or energy, and at least 3 of the following symptoms or the following behaviors have changed from baseline. And it's not always 3. You need 4 if the mood is irritable, 3 if the mood is elevated or expansive. So it's kind of a nightmare diagnosis to diagnose, but let's work through it again. So if the mood is elevated, you need 4 more symptoms, plus abnormal increased activity and energy. If you have irritable mood, if you have elevated, you need 3 symptoms plus abnormality. If you have irritable mood, you need 4 symptoms and abnormality. So this is hard even for you're a professor. All right, what are those symptoms that you need to have those extra symptoms? So increased in goal-directed activity, pleasurable activity, or psychomotor agitation. So you're either, you might be chasing reward in various flavors, or you might be like a beagle. I gotta go, 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 go. Talkativeness is you're kind of a blabbermouth, and it's very rapid. Everything's coming out rapid fire. Flight of ideas, you have a sense that the person is thinking so quickly that their mouth is not catching up with what they're thinking, so their thoughts are racing. Decreased need for sleep. This is both a symptom and actually a way to impact mania, or to get the onset for mania, is interrupt a person's sleep. Increased self-esteem. This is a fun one. The belief that a person has a grandiosity, or the belief that the person has special talents, powers or abilities. It doesn't have to be psychotic. It can be like you're super sexy or super smart or super talented and super special, but it can stop short of psychosis. It does not need to cross into that direction. If it starts crossing in that direction, then you definitely know that you're talking about bipolar 1. So it can go into psychosis, doesn't have to. Your attention is changed. You are distractible, ADHD-like. Your attention is easily diverted. And then excessive involvement in activities that might have undesirable consequences, so like reckless spending and sexual behavior, drinking, driving, and drug use. So a lot of ways to really hurt yourself when you are having either a manic or hypomanic episode. So for a manic and hypomanic episode, and this matters because it takes you into bipolar 1 or bipolar 2. For a manic episode, the symptoms last 1 week, or they can last less than a week, but then the symptoms require hospitalization or include psychosis. So imagine a manic episode that lasts 3 days, but because you haven't slept for those 3 days and are starting to hallucinate, your family finally takes you to a hospital. And the symptoms can have to either cause significant distress or impairment. And I will tell you that lots of folk with mania will not find it distressing. They're having fun. But you will see functional impairment. They'll start a lot of projects. They can barely communicate. They look wild-eyed. Hypomanic episode is not as severe, so it has a slightly different criterion. It has the duration. You have to have at least 4 days. And it has to be clear changes in functioning, but not necessarily impairment. And no psychosis. If it's psychosis, then you've crossed into bipolar, into manic. So I'm not sure whether it's in the subsequent slides or not. I know we've covered this before. Remember, bipolar 1, all you need to meet criteria for bipolar 1 is 1 manic episode in your life. But for bipolar 2, since the manic episode doesn't have to be so intense, it's a hypomanic episode. You need 1 hypomanic episode and 1 depression episode at least in your life to meet bipolar 2. All right. Let's go ahead and watch a video and switch screens again.
Hello there, Mr. Riley.
Hello, you all right? Yeah.
My name's Dr. Betty,
Right.
and I'm the
Right. I'll come and
psychiatrist.
see you because my GP sent me to see you, didn't
Yeah,
he? She said,
yeah.
come and see a trick psychiatrist because then you'll be all right.
Come and see her.
Trick psychiatrist, yeah.
Oh, right,
You must have
okay.
that one. Yeah, he said, come and
Yeah.
see because you have time to listen to him.
Yeah.
He's not had time to listen to him, you see, because
Okay.
he's a GP, he's a
Right.
doctor, he's very clever.
Can I just...
He's not very clever because he's not get into this. You see, won't let me talk about this. He talks this sometime, but then sometimes he doesn't.
Can I just clarify why you're here and why I'm here? I'm the psychiatrist in the emergency clinic today, and your GP's asked me to see you.
So that's what I mean.
Is that right?
Because I've got to tell you about this.
Okay.
Yeah, and this, because there's important stuff in it. Really important stuff.
Before we start with that, can I just ask you, what would you like me to call you, Mr. Riley?
Well, names are games, so I don't bother with names. That's just stupid.
Okay.
Call me John.
John.
Yeah, okay, what's your name?
I'm Dr. Betty.
No, your proper name.
My name is Dr.
No, your proper name. Your name's not Doctor.
At work, I'm Dr. Betty.
You're a doctor. Doctor who? Diddly dang, waddly dang. It's good. Do you watch? That's fantastic.
Okay.
Now, what
John,
is... Yeah,
can I ask you, how old are you, John?
Darry, only as old as the woman you feel, aren't you, eh?
Right, okay.
You know, what the man's heart is to his stomach. Oh, yeah, fantastic.
So how old would that make you, John?
Food for the soul. Nice bit of soul, yeah.
Right.
No, a bit of fish. And I'm hungry. Got any food? Any food around here? Wait, down there, you got any food? I'm starving now.
They won't be able to get you any food.
No,
Shall we perhaps... I'll tell you what,
okay,
let's think about food
get back to
in a
this.
minute. Yes, that's a good idea.
This is important. This is why I'm here to talk to you about this.
Okay,
Tell you what's going on.
Tell me a bit about this then.
Well, this is the work I've been doing.
Right.
This is really important, and it's my cure for cancer.
Okay.
That's what it is, you know. It's all written down here.
Right.
What's not written down, it's here, and it's at home in the books at home.
Right.
What I get from the papers is I get sort of clues as to what I'm supposed to do, and I'm supposed to get the other clues so I can hone it down and come up with a final thing.
And how long, John, has all of this been going on?
It's been for ages now.
How long would you say?
Ages now. Well, I've been up a week.
About a week?
But this week I've been working really hard.
It's
been going on longer than a week, but I've been working it really hard for this week.
Because you normally have enough...
It's the numbers you have to find out.
Am I right in thinking you normally do a different job?
Yeah, I'm a mechanic.
You're a mechanic?
Car mechanic, yeah.
Okay.
Yeah. Manic mechanic, they call me.
Manic mechanic?
Yeah, it was my mate Dave. My mate Dave. My mate Dave, I showed him this, and he told me, he told me to go away because it was bonkers.
He said you were bonkers?
He didn't say go away, he told me to fuck off.
My goodness,
He said fuck off, you're bonkers.
Did he?
Anyway, so he did that. And so I said, well, I didn't think he was clever enough.
Right.
Because I went to see the doctor about it, because I thought, show him, because he's a doctor, he's been to university, he's done stuff. Thick as shit. He really didn't have time. I thought, how can you not have time to hear about the cure for cancer?
Right.
You know what I mean?
Okay.
Yeah. So that's why he sent me to see you, because I'm told you about it.
Okay, well, tell me about it.
Okay, I've got my various bits and pieces here, and I'll find things in the papers, like, the football results, you see, they need adding together, and then I have to find some other information on this page. There's some pages and page numbers. Add those together and take it away from what's on there. Yeah? Right. So that's how I do that, and then
what does that number do?
You find other things. That number corresponds to numbers I've got on my chart. I've got a big chart on the wall. Right. And I'll find that number, and then that adds up to something else. And it's all there. I mean, that's really good. I'm going to get one of those.
What's that?
That's really good. That's a phone. It does the internet and everything, so I'll be able to find out more stuff. Right. That way when I'm out and about. But and there's numbers, you see. I'll use those numbers there. They need adding up and taking away from something.
And John, when you've done all this with all the numbers in the chart, where will that leave you? What is it you're headed for?
Well, it's cure for cancer, isn't it?
Cure for cancer?
Cure for cancer.
Okay. How's that going to work then?
Well, how it works is God tells me, I'm doing a really good job, how great I am, how fantastic it is I'm working at this, and I'll just keep going at it. I don't stop.
Okay. Yeah. Can I just take you back a step?
Yeah,
you said God tells you.
God tells me.
Can you tell me a bit more about that?
Well, he tells me. He just talks to me.
He talks.
He talks to me. He tells me, I'm doing a really good job, and I'm fantastic.
So God
really
talks to you.
Wonderful, and I'm great.
And when God talks,
I'll have to show this to people.
Right.
That's why I'm coming to show you.
And John, when God talks to you, can I just clarify this with you? What? Does he talk to you like I'm talking to you, with the voice coming through your ears? Or does it feel more
voice doesn't come to your ears, comes out your mouth. Voice comes out your mouth and goes in your ears.
That's right.
Yeah, you should know that because, you're a doctor as well, aren't you? So you should know these things.
And is that how the voice seems to you?
I hear him in my ears because that's what I'm used to hearing. And, and he talks to me with his mouth because,
So the voice seems to come through your ears rather than inside your head?
It's quite loud because he's a big bloke.
Is he a big bloke?
He's a big bloke, yeah. And he's got a big beard.
What's he like then?
Well, he's big bloke, big beard, yeah. I called him Beardy once, he didn't like it. Right up. Oh, Christ, you got the right call, call him Beardy.
Okay, I can imagine.
Yeah.
What kind of things?
Just sir.
You call
You
him
know, he
sir.
likes to be called sir.
Okay.
Yeah.
And what kind of things, when he's talking to you, what kind of things does he say to you, John?
He tells me I am fantastic.
Right.
You know, how great
Okay.
I am for doing this. You know, get stuck into this and keeping at it, and I should show it to people.
Right.
And that's what
Okay.
I've got to do. And I'll come out and I'll show it to people.
So who have you been
This
showing it
stuff.
to?
Well, okay. I've sent copies of stuff to the Pope.
Right.
And the Archbishop of Canterbury, none of them are written back. You think they would, you know?
So
Because
no
they're close to
replies
God, they
yet.
probably know him.
Right.
You know, they probably met him and stuff. You know,
Yeah.
God, with the Pope, he came to meet him. I mean, you
Right.
don't know.
Yeah.
I would assume the Pope knows God.
Right.
You know, he's
Okay.
God's address, his telephone number, everything like that.
Right.
But you know, then I would say Archbishop of Canterbury, I think he's just rude because he's not getting back at all.
Right.
And there's Toby Blair.
So you've written to Tony Blair as well?
Yeah, he's
Okay.
right.
And what did he say?
What?
What did
Nothing.
Tony say?
Nothing. I got a letter back. Well, I didn't even get a letter back from him. I got it back from somebody else.
Right.
Not him.
Okay.
They could have got lost to the post and somebody got it by mistake, but
So
just
John,
hoping nobody's stolen my ideas,
it
really,
sounds,
because
John,
it's
as
just
though-
what it is. I mean,
sorry to interrupt. It
It's okay.
sounds, John, as though this has all been keeping you really busy.
really busy, really busy.
Have you been sleeping at
No,
all?
no time to sleep.
No time to sleep.
no.
When was the last time you had a good night's sleep, would you say?
Don't need it.
Don't
I need it. I've got this
Okay.
enthusiasm from God, you know, it's
Right.
there, so there's
So what's your
energy
en-
inside me.
So you feel as though you've got a lot of energy?
Yeah.
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 And how are your
Tons of it,
thoughts?
tons
Are they going fast? Are you thinking
Well,
lots,
yeah, because I
lots of
have to think
ideas?
very intensely. You know, I mean,
Right.
you look at stuff down here. I mean,
Yeah.
there's no. You know, I got that in the door the other day. You know,
Okay.
and there's lots of numbers on there, and you're adding up and taking away.
And John,
other
how are you
numbers.
feeling about yourself? You know, and your self-esteem. How do you feel about yourself as a person at the moment?
Fantastic.
You feel
I
fantastic.
feel fantastic because you know God's telling me I am. Yeah, I'm doing a really, really good job.
Yeah.
It's all there. It's all happening.
And tell me this, John, because I couldn't get it from your GP letter. Have you ever had anything like this before in your life, where you felt full of energy and lots of bright ideas?
No,
It's
no,
not
but this has
happened
been
before.
going on for so long that I can't really remember anything else. You know.
And have there ever been any times in your life when you've
Yeah.
kind of been the opposite, John? Where you've been a bit down in the dumps, not much energy, nothing like that?
Nothing like that. No.
Okay.
No.
And what about any family history? Does anyone in your family have things
No,
like
it's
this?
just me. I was just me. It's really well. They're not that really that clever.
Who's not that clever?
My family.
Your family.
You know,
Okay.
that's why I have to come and see doctors and you know, place up hospitals and things like that.
Because
they're not clever
Right.
person. This is
Do you
what-
feel as though you're more
Yeah.
clever than perhaps other people?
Well, yeah.
Right.
No, I'm certainly clever enough to make it work. You know, because they're a bit thick.
And John, I guess I'm just wondering what might have happened to start all this off for you. Have you any thoughts yourself to put this on?
Well, God. Yeah.
God.
Yeah.
Okay.
Yeah. And it just came to me one day.
Right.
One day just came to me. You know, so I started noticing connections with numbers and things.
Yeah.
And it's
I
all
wondered-
there. You've just got to find it.
Okay. I wonder,
dig
John.
deep and look for it. You know what I mean?
Okay. How have you been feeling physically in your physical health?
Physically-
Any problems there?
Fine. I'm fine. Yeah.
And have you been taking any prescribed medication or even
No, nothing
any
like
drugs
that.
that
No,
are
it's
prescribed, any
just-
substances?
I just need everything within me now. I don't need anything else.
And you know how you were saying that your mate at work said
Yeah.
that you were
Who, Dave?
yeah.
Yeah, he said rude things.
He said rude
Yeah,
things.
I don't like the people.
He kind of suggested that
I told you
you
what
might
I said,
be.
didn't I?
Yeah, you did. You
It's the
did.
F word. I don't like that.
No. But it sounded like he thought you weren't very well at the moment.
No, I'm fine.
What do you think to that? Do
No,
you think
look,
there's-
can we look at this now? Because this is what I want to talk about.
Right.
I've come here to talk about this, and you see me going off from something
Yeah,
else that you're not really paying attention to.
Yeah, I guess
Do you
what
want to do that now? Can we look a bit more at this now?
well, I guess before we get back into that, I guess
Well,
what,
no, I don't want to get back in. I want to talk to you about it now. Can we talk about it now, please?
I guess, John, what I'm wondering is whether this might be a sign that you're not very well at the moment.
No, I'm fine. I want to talk about this. You seem to want to change the subject, so I
Yeah.
don't want to talk to you anymore. I've had enough of you, and I've had enough of being here. I want to talk to somebody else. I want to talk to the boss. I want to talk to your boss. Where's your
Right.
boss?
John,
Where's
I am the boss.
Well,
I'm
you're a shit
consultant.
boss, and I want to talk to somebody else. There must be somebody else I can talk to.
There isn't,
I want to
John.
talk to the head man. I'm fed up with talking to all you rag. I want to talk to the engineer. No more monkeys. The organ grinder for me. I want to talk to the top man. Top boss, top cat. That's what I'm talking to. Top cat. Yeah.
Well, that was fun. Switch screens. All right, hopefully I'm on the right screen here. I kind of feel bad for the therapist who has to interview him. He's a very easy case to diagnose with bipolar something or other, and she's doing the wonderful, wonderful job, but I applaud her patience. I started tuning out somewhere along the line of when he was trying to explain. Moving on, I want to make some distinctions between bipolar and unipolar symptoms. Bipolar and unipolar depression, for example, and like what the difference is, because I know most chapters, most books, even most lectures will put bipolar and unipolar disorders side by side, bipolar disorder and unipolar depression. Is that really warranted? What are the similarities? So bipolar disorder, manic episodes. So compared within a person's manic episode and their depression episode. The manic episodes are going to be shorter, but there's going to be more episodes during the lifetime. Depression, quite the opposite, longer episodes, but not as many of them. Now, what about depressive episodes in bipolar versus unipolar folks? So depressive episodes within a bipolar diagnosis seem to be more severe than unipolar depression, and they have greater mood fluctuations. That's what lability means. More psychotic features during the mood episode, the depression episode, more substance abuse, and greater psychomotor retardation, the physically slowing down that you were seeing in the other video. Other thing I want to say is bipolar, which I hadn't said in the previous slide. Bipolar, like schizophrenia, is one of our few truly lifetime neurodegenerative disorders. Once you have it, there's no growing out of it, as there is with quite a few diagnoses, which fluctuate quite a bit throughout the lifetime. Bipolar, once you develop it, you're in it. And full recovery is very rare. And even so, if you have a manic episode, 24% will relapse within 6 months, 77% will relapse within 7 years to manic or depressive episode within bipolar, 82% will relapse within 7 years. So treatment and management of bipolar is mainly about managing symptoms and trying to prevent the onset of manic or bipolar episodes rather than any kind of recovery, because recovery isn't something that you can hope for here. Really have to watch out comorbidity with substance use disorders. All right. Epistats. It's not a highly prevalent disorder. True bipolar 1 disorder is about 1% in the US, about 0.6% worldwide. For bipolar 2, it's a little bit more spread out, but that's partially because the diagnosis is not as reliable. You saw even I make mistakes, and it's pretty easy to make a diagnostic mistake for bipolar 1 versus bipolar 2 because of the complexities of diagnosis. Average age of onset is going to be late teens, early 20s, about 20 to 22 is about the mean. There doesn't seem to be any differences in rates of bipolar in women to men. The course is going to be lifetime for the rest of your life and episodic. Comorbidity. The most common comorbidity is actually going to be depression, but that's not true comorbidity because it's actually part and parcel with the disorder. It's actually probably why it ended up on the internalizing spectrum, is because it's always done with depression, or almost always. The next highest comorbidity is substance use disorders. Basically, so it's bipolar disorder with the externalizing spectrum. Could be some kind of self-medication. It's really not clear because they'll use one when they're manic, when they're depressed. Sometimes it's coping, trying to reduce negative affect. Sometimes it's trying to maintain positive affect. It is considered a type of severe mental illness. To illustrate why that is, a third are going to be unemployed after hospitalization. They're going to have a very difficult time being reintegrated into the community and what we call a normal lifestyle. And also the suicide rates are very, very high. So it's it's a huge, it's a very serious disorder, and unfortunately not one that we as psychologists or psychiatrists know about a ton. So let's go through some contributing factors. We do know quite a bit about the genetic factors or at least heritability estimates in bipolar disorder. This is probably one of our most heritable disorders. 80 to 90% heritability. I think the last 93% bipolar disorder, 93% heritability estimate. The rest is accounted for by non-shared environment. This is whopping huge. So this is a higher heritability than even schizophrenia. Okay, but what happens when you start going and fishing for genes? As always, no single gene is going to be associated with bipolar, no single gene. Just like in schizophrenia, I think they've counted about over 100 genes at least that contribute to bipolar. Those are shared genes, same genes that provide a liability to schizophrenia. And that's what it says here is genetic vulnerabilities as well as risk factors overlap heavily with schizophrenia. For a while, people had a hypothesis floating around is that just like bipolar is too little of the monoamines of norepinephrine, dopamine, and serotonin, there was a thought that there's too much of it in bipolar. You know what was consistent with that is that you could actually induce an onset of manic episode by giving a bipolar person SSRIs. As you guys can see, that's incredibly simplistic. So that's unlikely to be true. Something is altered in terms of serotonin and dopamine, but it's not clear how it's altered. You'll see it's a similar disorder to schizophrenia. Serotonin and dopamine are altered in schizophrenia, but they're actually altered in both directions. I'm sure something like that is happening with bipolar. Hormonal factors, just like with depression, we know that there's elevated cortisol during depressive episodes. That's not happening during the manic episodes within bipolar. On the other hand, we know that a thyroid hormone, a thyroid supplement can precipitate a manic episode. A few things can precipitate a manic episode. Basically, internal changes of the internal homeostasis seem to be precipitative of a manic episode once you've already developed the disorder. And to illustrate, disruptions in sleep patterns can trigger manic episodes. You see seasonal patterns. And what else? You actually, don't know if it's on the next slide, it might be, is goal achievement, getting something good, getting something that you want, having a kid, getting an A in school, can actually promote the relapse or the onset of a manic episode. So disruptions in sleep, too much goal-directed activity, goal achievement, and stress. Seems to be whatever throws you off the normal schedule, it may be liable to produce a manic episode. Right. It's unsurprising that it's a summary slide, just like I had with depression. So if you go through neurobiological stuff, huge whopping genetic contribution. We seem to have serotonin dopamine receptor dysfunction in it. Don't know in which direction. Cortisol dysregulation, yes, for the depressive portion, something may be going on with manic portion, but probably not. Yes, limbic system is involved, but how? Huge whopping response in the striatum to reward, and that is actually consistent with the idea of an overactive drive that does not know how to turn itself off in bipolar. Similar regions as in depression, which is actually why they have it side by side. But you see elevated activity in the amygdala and anterior cingulate, so that's limbic system. Dorsolateral or prefrontal cortex, diminished hypofrontality, similar to schizophrenia and depression. Diminished in hippocampus suggests, again, HPA axis, oops. And elevated activity in the striatum in response to reward, to be contrasted with depression, where it's actually reduced. All right. This seems to be a repeat slide, so I'm going to skip through this. So this is more of the same. Triggers of depressive episodes in bipolar disorder seem to be very similar to triggers of episodes in unipolar depression. Negative life events, neuroticism, negative cognitions, expressed emotion, that's the family structure and family interactions, lack of social support, and again, predictors of mania, reward sensitivity, goal achievement, sleep disruption. If you guys want to know, one of the ways that they try to manage bipolar disorder is putting a person on a really stable biological rhythms and interpersonal rhythms, and to try to manage the family so it doesn't, so the amount of negative conflictual interactions is reduced. All right. I'm going to take a drink of water, and then we are going to talk about suicidality for a second. Okay, listen up, guys. It's about to get real interesting in terms of theory. We're going to be talking about why people commit suicide and how. I'm going to refer back to the original video, the very first video we watched today with Allison, the woman who comes to the office with depression. But we need to define some key terms here, because not all suicide-related behaviors are the same. Suicide ideation, self-explanatory. That is the thoughts of killing yourself. Suicide attempt, and that's behavior actually intended to kill oneself. Suicide is the actual death from inflicting harm to yourself. And finally, here's one. Non-suicidal self-injury. Those are behaviors that are intended to injure yourself, like cutting or burning yourself on purpose, without actually an intent to kill yourself. Now ask yourself, the woman Allison who we saw in the depression video, did she mean to kill herself? Did she not quite mean to kill herself? Well, she was definitely working in that direction, although it was a lot closer to suicide attempt than non-suicidal self-injury. But her motive was not clear-cut of, oh, I'm going to kill myself. And that's actually common. Very quickly, before I move on, people do make the point of distinguishing between non-suicidal self-injury and the actual suicide attempts, because the motivations are different. In NSSI, it's a lot more about mood regulation or social regulation, whereas in suicide, well, it's also mood regulation. But the difference in suicidal attempts, is that you have an intent to die. NSSI, not so much. There's no intent to die. There's usually some other motivation. But they're tied. They're tied very strongly. NSSI will predict suicidal ideation in the future. And also, people who are engaged in NSSI, they can kill themselves by accident without actually meaning to do so, because they've chosen something a little bit too lethal for the engagement of NSSI, maybe a knife too sharp, a cut too deep. Could happen and does happen. So plenty of reported cases of NSSI going too far, turning into suicide without intent. All right, rates. In the US right now, the rates seem to be about 1 in 10,000 in any given year, and worldwide. Suicidal ideation is, it's not rare. 9% of folk report suicidal ideation at least once in their lives, and that's worldwide. And 2.5% worldwide have made at least one suicide attempt. So it's a fairly serious problem that we're dealing with. Some stats that you may or may not know about. Men are 4 times more likely than women to kill themselves. Women are more likely than men to try. Guns are the most common method of suicide. Usually men will go for guns or hanging. Women are more likely to use pills. So women end up using methods that are not as lethal as the men. The rates of suicide increases in old age, and you're going to see the chart for risk factors in just a second. But the folks most at risk for suicide are white males over the age of 50, and if they're divorced, they're really in trouble. And what's really alarming is rate of suicide for adolescents and kids is increasing dramatically. Being divorced or widowed increases suicide 4 or 5-fold. These are huge, scary numbers, folks. Let's take a look at what this actually looks like. This is per 100,000 people. This is numbers per 100,000 people. So it doesn't seem like it's impressive, but it is people's lives. So age 5 to 14, girl, this is actual suicides, actual suicides. Age 5 to 14, men and women, boys and girls more like. This is already not trivial. And then you look at the age group 15 to 24, again, men are doing a lot more completing than women. Not a trivial number, and it just keeps going up throughout the years. Now let's look at by gender, age, and ethnicity simultaneously. So you can kind of see where the risk factors are. White males, so the light blue, I believe, is white male. The yellow is, the orange is white female, the yellow is black female, and the purple is black male, it looks like. So white males, hugely at risk for suicide, and it just increases with age. But there's also quite a bit of a risk factor here, again, between, for a while, between 30s and 60s, and it gets even worse. And then black males have an increase of risk between that 15 and then 40. This is terrible, guys. And then, but fortunately, then the risk decreases. And then women are much less risk for, remember, this is completed suicide. This isn't attempted suicide. If it was attempted, it would look probably quite different. But with completed suicide, white females start getting at risk again in the same time that the white males are becoming at risk, but then it declines afterwards. And African American females are I believe they're the group that is least at risk throughout the years. So an interesting slide, and it's actually consistent with what we've talked about in differing rates of depression among whites and African Americans. This is across the world. Just for you guys' knowledge, the areas in red have huge rates of suicide, so India and what looks like Europe and Russia really have huge risks of suicide. North America is pretty up there. Canada is less. And then some places are less at risk than others. But it's not exactly just a local problem. In Europe, it's a major problem. India, and then Africa, including some piece of I guess it's the East Coast, and I think Sub-Saharan, if I remember correctly, my geography, maybe not. You get the point. Are there biological factors contributing to suicide, like genetic and whatnot? Of course, because there's biological factors contributing to everything. If something happens to you, it's going to be expressed in the brain. If you start changing your behavior, it's going to be expressed in the brain. Okay, so so unsurprisingly, This is heritable. Suicide rates are heritable. I only have one statistic on the actual slide, but if you look at the notes sheet, which I generally post, I just reviewed an article. So heritability goes between 33 and 53 for suicide ideation and attempt. So up to 50, basically up to 50% heritability, but that's pretty normal for twin studies. While I'm at it, I will also note that NSSI, not suicidal self-injury, is also heritable. It's actually more heritable. It's got about 60% heritability. Then people think, okay, reduced serotonergic activity, not so much serotonin floating around. Once again, be very careful. I don't trust this reduced increased thing, and I think it's going to get slammed even more as the years go by. It's probably, serotonin is probably involved, but probably in a very different manner than we think. And as with depression, you see an overly reactive HPA system. But that could be comorbidity with depression acting up. It could be not anything specific to suicide or suicidal ideation. So, what kind of disorders increase the risk of suicide? And it's interesting. It's PTSD, bipolar, as I've mentioned, and then something interesting happens. Conduct, antisocial, and borderline. But all of this stuff has an important trait worked into it, and that's impulsivity. There's a lot of impulsivity floating around in these disorders. And impulsivity, trait impulsivity, suicide is generally an impulsive decision. So impulsivity increases the risk for actually committing suicide, for making it happen in the moment. And if you remember how the woman that we started with, Allison, there was substance abuse involved in her suicide attempt, so she had a few glasses of wine. And it was it was an impulsive decision. And she also, there was very clear hopelessness. She had a lot of the other factors, the negative emotionality, and can't remember, I don't think we heard anything about her family history. But all of these factors are going to be actually associated with trying to complete suicide, actually attempting suicide. What else to say about this? Not much. And then we're going to go on to a theory that even I like. Lots of people like this theory. I think it has a name of the interpersonal model of suicide, but I sometimes just refer to it as the acquired capability model or Joiner's model. And then everybody knows what I'm talking about. So let's get into it. Tom Joiner starts his talks and his book with the following words: suicide is not for the faint of heart. What does that mean? It means suicide is terrifying. It is really scary. The other thing he puts in his books and sometimes in his talks is the story of how his father committed suicide. Tom was the one to find his father, and it appeared that what he did, the dad, is he took a tequila bottle and a knife, and he started hacking himself. He couldn't get himself to finish it up right then and there, but it looks like he really hacked into himself in several different places before he actually worked up the courage to kill himself. This is a story that got an experience that got Tom Joiner into studying depression and suicide. It's a healthy way to channel that sort of thing. But that got Tom thinking that suicide is really scary. It's not, it takes a lot to override the desire to live. So he thinks we actually acquire the capability for suicide. How does this work? So foundation of this theory. People die by suicide because they can and because they want to. So Tom thinks two potentially, well, not potentially, painful states. that contribute to suicidal desire. And those are perceived burdenlessness. I'm a burden to other people. It would be better if I wasn't alive. It would be better that I die. And then thwarted belongingness is you want to belong. You want to belong to a social group. You want to be accepted. It's a fundamental human need to want to be part of a relationship or a social group, and you can't. It's not being, somehow you don't feel like you're accepted or integrated into a social group. These factors contribute to desire, but they're not necessarily going to contribute to active suicide. Okay, acquired capability for suicide happens when you start experimenting with it. When you start experimenting with suicidal type behavior by non-suicidal self-injury, by cutting or burning yourself on purpose. Together, when you take all of these together, you have a huge risk for suicide. What are the empirical studies? We know that, so Tom has shown in 4 different samples that NSSI predicts suicide even when you control for a lot of other factors, family history, personality disorders, psychopathology. He didn't really control for everything under the sun, but he controlled for a lot. So it seems that NSSI is predicting suicide directly, independent of depression, independent of shared traits, independent of shared mechanism, which seems to be a direct translation. Something about doing NSSI makes you more likely to commit suicide. And what is it? It's habituation. It's you learn not to fear it. You maybe have a reduction in pain. What else about this? And that's actually, that's why NSSI and past history are always major risk factors for current completion of suicide, is because we think, oh crap, this person has already habituated to this. It's going to be easier for them to commit suicide. They're not going to be as scared. And when you have a person with a history, you should be worried. You should be worried, and you should be thinking very hard, what do I do to prevent risk? All right. Everything else is in my notes under the slides, so that should work. I did put in a couple of slides just to talk about crisis intervention. It's not easy, and can't teach you everything about crisis intervention in the space of this lesson, but a couple of things I think are going to be helpful. One is you maintain in contact with the person. You don't just leave them alone. Then you want to try to show them that their cognitive filter is making them see everything in black color, like they've got black colored glasses on instead of rose-colored glasses. As you didn't always think that way. You didn't always consider that the world was hopeless. You're thinking it now, but this is partially your distress. And then you try to show that the distress is actually not endless. That it's time limited, and that pain, like any pain, comes in waves. It ebbs and flows. To be perfectly honest, all of that seems like Band-Aid solutions to somebody who is in crisis, but it's a lot better than nothing if your friend comes to you with a suicidal ideation. So basically you try to keep them safe, and then if the risk is high, then you want to get them to a mental health professional or consider Baker Act as an option. Here's some phone numbers. Like I said, what can you do? You believe that they're at risk. You take it seriously. There's a number of risk factors that you could assess, but any NSSI or past history of suicide attempts is going to be a huge problematic. Here's some crisis hotlines. And then there's always the option of a Baker Act if it's absolutely needed. If it's during business hours and we're around, just get one of the folk in the clinical psychology department or in the clinic. We're around, or we try to be. I'm going to skip the video because it's already been kind of a long lecture, and I'm not sure whether it's going to convert, but you guys should take a look at it at your own time if possible. Thank you, and I'm hoping that this will convert correctly and that you guys will have found it helpful.